I'm going to ask my panelists to join me here on stage. So this really is an opportunity to have three folks who are working in innovation give us an idea, just very briefly, of what they're doing. Once we do that, we're going to try to leave 10 minutes or so at the end for folks to ask questions if you have questions, or throw tomatoes or whatever it is you would like to do at that point. We're going to start off with Tolu Uyatunji. He is a pediatric surgeon at Children's Mercy, and he's an assistant professor of pediatric surgery at the Kansas School of Medicine. So, Tolu.
Good afternoon. All right, so I'll be just sharing with you what I call surgeons and engineers. And just so I apologize ahead, I use that term engineer very loosely, so don't be upset. So why surgery? Why surgical innovation? I think things have been done the same way for a very long time. As you can see, the history, we don't change a lot of things. We kind of do things, we're taught the same way. It's more of an apprenticeship model. So it's the way I was taught, it's the way I do it. And there's nothing wrong with that. If it's not broken, you don't want to fix it. But the question is, it's not about the type of surgery we do, but it's questioning how we do the surgery in 2019. And there are a lot of surgeries in the United States only. I mean, we're talking upwards of 20 million visits in the United States for surgeries only. And these have huge patient impact. You know, they may not be like some of the other things that we've heard about, but in that little world of surgery, these things do impact patients a lot. And if you've ever had a kid or a family member go through surgery, you know how stressful that can be. And I feel we surgeons are pretty motivated. If you've ever been with a surgeon, we're kind of straight to the point, and we do like to get things moving along real quick. So I think we're driven in terms of that. There are definitely opportunities for tech transfer startups. And overall, I think we can reshape the surgical landscape and really bring surgery to the 21st century versus what we do right now. So, you know, when I made this slide, I was joking like I didn't even know what was going to be presented, but we've heard a lot about the things on your left. People talk a lot about minimally invasive surgery, robotics, and you still hear a lot of that today. Image-guided surgery, optics, you know, cameras, and also medical imaging. Those are the things people hear when you hear innovation, but there are a ton of things that we don't talk about that will be very applicable in surgery. And I've listed some of the things to the right, which are some of the challenges I've had just trying to work with devices. And just to, again, this is not limited. I think you should broaden your scope of what you can do in the field of surgery. So this is my drawing, as you can see. I'm glad I just stayed with my first job, because that is really a very bad drawing. But that was my idea. And thankfully, somebody had a daytime job that can do a better drawing than I do. So this is what a device we're working on, and this is meant to be a device sort of for feeding. And we're trying to figure out how best to, you know, design this device to work in a very small baby. I mean, we're talking about neonates, kids just about 28 days old. And this was the first one after back and forth discussion. Of course, I had a bit of a redesign. And what are some of the things we're talking about as I discussed with people? We're talking about what kind of material do you want to use. These were questions I probably never really thought about. And they're like, if you're using this material, this is what's going to happen. What kind of valve system do you need? I never knew there were so many valves. Let's start with that. It's such a confusing thing. And then the fluid dynamics. How do you want the fluid to flow through the tube? What's the impact of gravity, unidirectional flow, you know? And other materials that we wanted to look at to make this device work. As we kept going along, of course, this involved a redesign, changed what we wanted to do, and that's what you kind of see from what I had before to what is now on your screen right. It's totally not the same. But that's where the device headed to after a bit of input. The interesting thing is this took a long time, just because we did not have, I mean, we're not like some other places. Some people have that. I think it was, somebody mentioned this morning and talked about passion. It's not just you want to do innovation. It has to be something you wake up every morning thinking about. And you need that on both sides, those that are collaborating with you and you that you're doing the innovation too. And we didn't get that, but just to know that the need is definitely there. So this is just another example of another device. That's the one to your screen left that we're working on in terms of this is more for a device I want to be able to place on the skin and connect another device to. And what are the potential needs for our project? I mean, mechanical engineering, biomaterials, fluid dynamics, sensor design. Those are some of the things we've thought about that we feel we can collaborate with people. And where can we get this? I know it's challenging to work with surgeons. We're busy. And it's not everybody that has some kind of protected time in terms of academia versus a private group. And some people, change is hard. They've done the same way for a long time, so it's going to take a bit of convincing to change practice. But you know, they're always early adopters, and I think my institution, I feel we're definitely early adopters in terms of doing things new. So what's the future? It's interesting. I think Dan had a similar slide that said the future is now. So that wasn't planned. So there are many collaborations. Vanderbilt is a good example. Georgia Tech and Emory also one. But I think there's always welcome opportunity for independent design firms to collaborate with surgeons because, I mean, the impact is pretty huge. There's just the little things. It may not be the big robotic surgery, but the process of how we do things, the instrumentations are things that we can change. If I believe what Dan probably used to train, the same instruments we're thought to use. Can we change? Can we renovate? Can we do something differently? And so collaboration is a start. But it's not the end. I think the field is not saturated at all when it comes to surgery. There are many things that can be done. It has to be a mission and a passion to reinvent surgery, and this needs kind of visionary research and also partnership. And definitely it takes out of the box thinking. Thanks.
Thank you, Tolu. So the next speaker is actually a great colleague of mine. John Ricadio is one of the interventional radiologists at Cincinnati Children's. And John and I have been working on as he said, I forget what you called it, your evil plan for an image-guided surgery center. And John's going to tell us a little bit about that.
Thanks, Dan, and it's a pleasure to be here. As Dan mentioned, I'm going to extend along the collaboration theme here. And as a background, what interventional radiologists do and what surgeons do and those procedures, those lines are becoming more and more blurred. And some of the emerging technologies are transcending any one specialty's traditional experience. So what we think is that interventional radiologists and surgeons working together is a better way to treat children. And the idea is to combine both our skill sets and our technology to help find new and novel ways to treat children. So as an overview, you know, particularly in the adult world, interventional radiology and surgery can have a lot of turf wars, adversarial relationships. We have actually an excellent collaborative relationship at Cincinnati. We want to carry that on even further. And one place that we can do that is on the research side and also on the clinical side, particularly in a hybrid operating room that we opened up recently in about a year and a half ago. So we're also fortunate that on the interventional side, we have had a long relationship with research with Philips Healthcare and their technologies that we use for imaging. And the way that we've set it up is we have the imaging technologies that we have capable in the research lab. We also have in the clinical hybrid operating room. And the idea is to create this image-guided surgery center of excellence where we bring surgeons from all disciplines and advance image guidance in the ORs. So here's a picture here of the research lab and then the clinical hybrid OR. And again, the idea is to bring what we do in research, in this case, is working on a new way of doing spine surgery with one of our spine surgeons using some augmented reality that's not yet FDA approved, but we're able to practice that in the research lab now. And then ultimately bring that to the clinical hybrid OR. There's a technology that we already have that we've been using in interventional for a long time where we superimpose a CT that we acquire in the suite with live or augmented fluoroscopy. And that's what we did here for a C2 fusion with one of our spine surgeons. This augmented reality is going to hopefully be out in a year or so, where they've incorporated video cameras in the flat detector of the C-arm. So now we can do things without X-ray and navigate just with the video guidance. So here's a little example from the research lab. Human cadaver
So there's a
monitor.
pretty good planned
We've done a
path.
CT scan,
On advancing
and there's a virtual needle that you see the green there.
down, advancing, I feel
What we
low.
do now is see the
Shockingly,
needle
it
for
seems to
each
match.
So it knows the distance and the length.
That's
And
good.
depending on how that needle is positioned,
the
you see
needle.
the trajectory that you're going to be going through to advance a screw to a
Camera, a
pedicle
little off a
and
little bit on the
spinal
bottom.
the spinal cord.
So we need to go a little more.
We looked at other ways to use this technology. Dan and I used this to localize pulmonary nodules in a piglet model and then have thoracoscopic resection. And then really along this idea of the collaboration, using the technology that we have right now with this augmented fluoroscopy, we can perform a CT scan of the patient that we're trying to remove a pulmonary nodule for, a very little small nodule. We can localize it right there in the operating room and then have immediate thoracoscopic resection, as opposed to the way we used to do it, which would be to scan the patient in radiology, localize it there, move the patient up to the OR, and then ultimately do the resection there. It's just this case breakdown. Again, trying to get all different subspecialties involved has been key. So we'll end here with a few cases. You know, it doesn't have to be the fancy technology. It can just be a collaborative approach where we use ultrasound. So in this case, the patient has a large mediastinal mass with a lymph node or a mass that's seen behind the clavicle that was not palpable by the surgeon. So we just use a little Copan's localization needle and wire, and we're able to advance the needle and then deploy the wire right in the mass, and the surgeon can just cut down on that and find that lymph node and resect it. Another one we've done with one of our plastic surgeons for a maxillary sinus mass. We can do, well, this is just CT from a few weeks prior to surgery. In the hybrid operating room, it takes the whole team to make sure that there's a free space between the table for the C-arm to spin around. And you'll see here as we rotate around, this is a CT acquisition on the operating. And then immediately you'll get a CT like this that we can segment out. It just takes a minute. And then the surgeon has this for preoperative planning, not only for the surgeon to plan the surgery, but also during the procedure, we can do another scan and look for tumor margins following the initial resection. So another example with one of our plastic surgeons is one with fibrous dysplasia of the skull and the orbit. A similar kind of thing where we rotate the C-arm around the patient, acquire the CT scan. We can segment this out. In this case, it was actually one of the first cases we did where they didn't really know the capabilities. And during the initial scan, after the first part of the resection, there was residual disease. And they said, well, I said, would it be helpful if I could put a little dot there where that is? So they said, oh, that'd be great. So just a matter of placing that dot in the software, and then you can lead the surgeon directly to the area that you need for further resection. And then finally, a case that just was from a few weeks ago, talking to the pulmonologist about looking for a better way to do transbronchial biopsies. And this is where CT scan, immediately get the CT. We can see that right lower lobe cavitary nodule. We can segment that out. And then we have live fluoroscopy superimposed as we move the X-ray tube from a different angle to make sure that the biopsy forceps are going directly through the area that needs to be biopsied. So we have all this displayed. We have the fluoro, the bronchoscopy, all displayed on a big monitor in the hybrid OR. So really, we can maybe talk about this in the question and answer session if we have time, but there's going to be some potential financial disincentives for collaboration. We talked about surgeons' egos. There's also interventional radiologist egos, but if we work beyond that, I think that's really the best way that we can treat kids.
Great. Thanks, John. Great. So we left a little bit of time for questions. If folks have questions, we'd be happy to try to address them. Questions from the audience? Suresh.
Two questions on your talk on innovations. The Da Vinci,
Yeah.
Da Vinci system, training surgeons who may not have trained using those instruments. Even using simulation and maybe even cadavers, things like that, how easy or hard, and how do hospitals train not just the current generation, this is training past generations of surgeons?
That's a very good question. The training on the Da Vinci was a challenge because was only one console and you were either operating or you weren't. And when you were teaching and you couldn't see what they were doing or you could only see on the flat screen, that was challenging. There is now a system set up, or the system is set up so that you can have two consoles for twice the price and you can have essentially somebody working with one, and the teaching assistant can take control if they want to. So it adds an element of safety to that. They also have introduced simulation programs that allow you to sit and work on the Da Vinci with no patient. It just connects to the computer in the simulation program. And in our institution, we have credentialing criteria that people, to get or maintain robotic privileges, you have to do a certain number of cases a year or spend a certain number of hours working on the simulator to keep your skills up as the technology evolves.
Thanks. A related question, as far as quality outcomes, validated surgical metrics like OR time, intra-op or post-op complications, are they significantly better with the robot?
That's a topic that you'll probably get a lot of different answers to. In terms of OR time, we actually studied it. We did 18 consecutive robotic Nissen fundoplications and 18 laparoscopic fundoplications, and it turned out that overall everything was essentially the same, except it costed a little more to do it with the robot. The OR time, it took a little longer to set up the robot, but you could operate faster once it was set up. And then the post-op time was all the length of stay and such was all the same because it's a minimally invasive procedure. The big difference for it, and this is the reason that it became very popular in urology, is a laparoscopic prostatectomy is a very technically difficult operation. And the robot allowed people who could not necessarily do that procedure using a minimally invasive technique, laparoscopy, to do it with the robot, which is a minimally invasive technique. So those patients would have had an open operation and a much longer length of stay, but they were converted to minimally invasive procedures because of the technical advantages of extending the capabilities of those surgeons to do those procedures.
Thank you.
Other questions from the group? All right. Very good. Thank you.